Hi everyone, so today we will be learning about complete denture and the classification of impression techniques. So to move on, introduction. What is meant by a complete denture impression? A complete denture impression is nothing but, according to GPT, it is a negative registration of the entire denture bearing, stabilizing and border seal areas that are present in the edentulous mouth. So which the entire denture bearing area as well as the areas which help to hold the denture, that is the stabilizing portion, and also the border seal areas. Now, what happens is that for a if the patient requires a prosthetic surgery or no prosthetic surgery, first we take a primary impression, and from that primary impression we pour a diagnostic cast, and from the diagnostic cast we make a special tray. That is, it is a custom tray which is according to the patient's size and shape of the denture. Now let's move on to the topic, that is classification of impression. So we can classify it according to various headings, like depending on the theories of impression making, depending on the technique that is used to take impression, non-hand manipulation for functional movements that you can also called as dynamic impression, depending on the type of tray used, depending on the purpose of impression, depending on the materials used. So these are the classifications on the basis what we classify the impression, taking impressions. So we'll deal every one in detail. So moving on to the first. Depending on the theories of making impression. We can begin with, we have mucostatic, passive, non-pressure, minimal pressure impression technique. So as the name itself, mucostatic means what? The mucosa is under a static condition. It means it is normal or a relaxed position. So here border molding is not done, and also when we're taking the impression, the tray which we select will be oversized and the material used will be impression plaster. Now the denture which we get from this type of impression technique will be closely adapted to the mucosa, and but the problem is, since there is no border molding, it may have a poor peripheral seal. The retention is mainly due to the interfacial surface tension. It will be mainly due to the interfacial surface tension, the retention that we get from mucostatic impression technique. Now these dentures will have good stability and poor retention. Next, we have the Mucocompressive impression technique, which was given by Carole Jones. Here, mucocompressive, it means the mucosa is under a compressed form. So here the oral tissues will be recorded in a functional and displaced form. For this, we use impression compound, waxes or soft liners for recording. Now what happens is that oral tissues, we know that these are having the property of resiliency. It means they will come to their original position when the force is being removed. So when you're making dentures using mucocompressive, it means when the oral tissues are in a functional or in a displaced form, after the function, this will get relapsed or it will rebound. Okay, when the tissues are at rest, it will get rebound. So what happens? We won't get the proper retention of the denture. During function, the constant pressure exerted on the soft tissues will limit the blood circulation, and it will also lead to residual rich resorption. Next, we have the selective pressure technique, which is given by Boucher. Here, selective pressure, it means somewhere you give selected pressure and somewhere you give no pressure. So the impression here, it extends towards the denture bearing area also, but it will not interfere with the limiting structures at function or at rest. It won't interfere. So here we have some stress bearing areas and non-stress bearing areas. So the non-stress bearing areas are relieved and the stress bearing areas are allowed to come in contact with the tray. Where there should not be stress, we relieve those areas like incisive papilla. Those are the structures where the nasopalatal vessels are being gone. So if we give due pressure over there, it can cause paralysis or even the nerves can be punctured or injured. So For non-stress bearing areas, we give relief, and for the stress bearing areas, we allow the tissue to come in contact with the tray. Now relief, usually it is given using wax in a special tray, and that should be removed before the final impression taking. So now we move on to the impression technique depending on the impression technique, whether it is open or closed. First, open mouth impression. Here open mouth means mouth is open, there is no function going on, so the tissues are recorded in a static with displacement, static state with displacement. We give pressure so it displaces, but in a static state. Now the amount of displacement will depend upon the ability of different oral tissues to withstand how much of pressure we are giving. So the amount of space provided for the impression material and the consistency of the impression material. Okay, so how much it can provide, it will depend upon the impression material that we are using and the consistency of the impression material. With the patient's mouth in open position, the dentist will apply a controlled pressure on the inserted tray and they will record these tissues in a static form. Here what happens, it is not in a functional state. We don't use many movements or nothing. We just ask the patient to open the mouth and we take the impression with that pressure, which is with the controlled pressure of our hand. Now while in closed mouth impression, it will record the tissues in a functional position. Now here we use certain record blocks which can be trays with occlusal rims. These are used instead of the impression trays. Now both upper and the lower record blocks will be lined with impression material and it will be placed inside the patient's mouth at the same time. Now the patient will be asked to close his mouth, exerting pressure on these occlusal rims, and now we perform different functional movements such as swallowing, grinding and pursing of the lips. Such movements will be asked to perform. Now the impression materials for this type of impression are impression compound can be used, waxes can be used and soft liners can be used. Now since the tissues are recorded in a functional compressed form, as we have said before, they will rebound at rest due to the resiliency. Okay, this can lead to denture displacement in future. Now denture base exerts constant pressure over the tissues and thereby again here what happens, the blood supply will be decreased or impaired and it can lead to rich resorption. Next we have the hand manipulated functional movement or dynamic impression technique. Now what it is defined as the shaping of the borders of an impression tray to conform accurately to the vestibular areas and border seal areas. That is green stick impression we are molding the borders of the impression tray. In this technique, a moldable material is added along the borders of the tray and seated in position. Now once this is done, now the dentist will show most of the passive functional movements of the lips, cheeks, so we will get a functional impression of the vestibular areas. The patient is also asked to perform the tongue movements to record the alveololingual sulcus areas. We ask the patient to bring the tongue forward, touch on the incisive papilla, touch on the opposite molars, and such movements, so we can properly record all the impression border areas, vestibular areas. Now, active opening and closing movements of the jaws are performed to record the distobuccal portion of both the impressions. Okay, opening and closing of the jaw. Distobuccal areas are also very important because we have for maxilla also there is an interference with the condyle. So these all things should be properly accurately measured and accurately impression should be taken. Now, depending on purpose of impression making, what is the purpose? Based on the purpose, why do we take impression? We can classify it as a diagnostic impression, primary or preliminary impression, final or secondary or the master impression. Now, first, according to the diagnostic impression means for diagnosis purpose or for treatment planning, for fabricating diagnostic cast. Okay, for these all reasons, we usually take a diagnostic impression. The name itself suggests it is done for diagnosis. Now, the materials used here are the irreversible hydrocolloids mainly. Now, primary impression means this is mainly done for on which we can construct a custom tray, that is a special tray. We take an impression, first we take an impression, with that we will make a customized tray for the patient. So for here we can use irreversible hydrocolloids, impression compound putty, and heavy body. Putty you can use, heavy body also you can use, elastomeric impression materials also can be used. Then coming on to the final secondary or master impression, this means we fabricate a master cast. Okay, for that purpose we are taking an secondary impression. So with the primary impression, we pour a cast, and from that we take a secondary special tray, means we fabricate a special tray or a custom tray with which we can take the final or the secondary impression. So here mainly we use metal oxides like zinc oxide, eugenol, impression paste, impression plaster can be used. Medium and light body elastomeric impression materials can also be used. These are based on the purpose of impression taking. Next we have depending on the impression materials. This is towards the last of the classification. We have plaster impression. Now type 1 dental plaster, which is soluble plaster, is used. This material has potato starch, which helps in easy separation of the cast from the impression. That's why it is called as a soluble plaster. Why? Because it has potato starch. That is type 1 dental plaster. The impression plaster is mixed with water in a prescribed ratio and it is loaded onto the tray. Now to separate the cast from the impression, the impression along with the cast should be inserted in a bowl of hot water. That's why it is called a soluble plaster, which will provide easy separation of the cast from the impression. Now the starch in the immersion plaster will swell up. Now we are seeing how it gets separated. Now the starch which is present in the impression plaster, it will swell up and break the impression, and thus it makes easy for the removal from the cast. Now impression plaster is generally avoided as it causes patient discomfort and has also poor handling characteristics since it is a plaster. Then we have impression compound. Now impression compound is a reversible thermoplastic material. Okay, it is a reversible as well as thermoplastic. It means we can manipulate it using the hot waters. It is softened in a water bath at 64 degrees Celsius and it is kneaded until a uniform mass is obtained. Now the impression is made using a stock tray. The advantage of it is low cost and it is very easy to use since it is a reversible material. Only thing we need is a water bath. It has good dimensional stability also, but excessive water incorporation during wet kneading, it can cause dimensional change also. So that is a disadvantage. If you are not using properly, then it can lead to dimensional changes. Now other disadvantage is it is viscous. As it is highly viscous, it can displace the tissue surface. It does not record surface details very accurately also. Next, we have the reversible hydrocolloid impression. You all know which all are the reversible hydrocolloid impression. It is impression makes use of agar. Okay. Here the agar is taken from the tempering section, which is at 46 degrees Celsius. So tempering section will be at 46 degrees Celsius and it is loaded onto a water-cooled rim lock tray, and then the impression is made using this rim lock tray. It has excellent surface detail reproduction, almost up to 25 microns. But the problem is it is having poor dimensional stability due to syneresis and imbibition. Since it is a hydrocolloid, there can be a syneresis and imbibition problem. It is an elastic material and can be used to record undercuts. Since it is elastic, it can flow into, like in the gel state, it can record the undercuts. Generally, elastic impression materials are indicating for recording the undercuts. So we can utilize its advantage for some problems. Like if there is an undercut, then we can utilize this agar to indicate, or you can take it for recording the undercuts properly. Next, we have irreversible hydrocolloid. We all use it very frequently. That is the alginate. So alginate is a hydrocolloid which is used for this type of impression. Like it is available. How it is available? It's available as a powder, which can be mixed with water in a rubber bowl. Now spatulation is carried out until a homogeneous mix is obtained. We all use this, right? Alginate most commonly. Then the mix is loaded onto the impression tray and the impression is taken. Now Why do we use it? Mostly because they have a better peripheral seal than any other impressions, and they are also very economic. They do not cause any cross infections as they are only used once. We do not reuse them because it is irreversible. But the advantage is poor dimensional stability. Again, as it is in a hydrocolloid, there can be syneresis and imbibition. All hydrocolloid impressions, whether it is reversible or irreversible, they should be poured immediately in order to avoid any syneresis or imbibition, after which they are made. So now we have come to the silicone impression. They are of two types, that is, we all know condensation polymerizing silicone as well as adhesion polymerizing silicone. Now condensation polymerization, they are available as a reactor paste and activator paste. Now we mix both of them in a ratio to produce a uniform mix and we take the impression. Now there is a dimensional instability for this, and it is because there is evaporation of ethyl alcohol from the impression. So they mainly lead to dimensional instability. That is a disadvantage. Now adhesion polymerizing silicone, this is also available as two varieties, namely in the tubes as well as in the cartridges. While using the tube form, the method of manipulation is similar to that of the condensation silicone, like you have to mix both of the tubes. But when you're using in a cartridge, they have to be dispensed in a dispenser guns and used accordingly. You must have seen when dispensing gun, they both come together and they both mix together in that dispenser gun itself. Now this variety of silicone does not undergo dimensional change. You can even pour the cast after a week also, but condensation you cannot do because there is a formation of ethyl alcohol and it evaporates from the impression, so it leads into a dimensional instability. Next to the last we reach, that is the thiokol rubber impression. Thiokol rubbers are basically polysulfide impression materials. They are polysulfide. Now, polysulfide materials as such, they are hydrophobic. Okay, so they are very hydrophobic in nature. They are available as base and accelerator paste. So manipulation is similar to any other elastomeric materials. Precaution should be taken to avoid any moisture contamination on the tissue surface since they are hydrophobic. Now, silicone and thiokol impression materials can be used as a secondary impression, and all other mentioned materials are used to take primary impressions. Okay,